Matthew Holt with the Healthcare Blog. It's my great pleasure to be here with Suzanne Delbanco. She is the Executive Director of a relatively new organization called Catalyst for Payment Reform. And no institute, no foundation, no nothing, that's just a Catalyst for Payment Reform. Suzanne's pretty well known in healthcare because she, for many years, I won't say exactly how many, but more than 5, she ran the Leapfrog Group, which is probably at this point best known as the one of the best known employer-based groups in healthcare advocating for essentially better healthcare for less money, using information technology and using quality indicators and many other factors. A lot of good work there. And Suzanne kind of ran away and hit off the scene a couple of years ago and has now re-emerged. And we're actually now, I went to show you guys the overview. We're in her temporary office in the Pacific Business Group on Health in downtown San Francisco, which has a lovely view, which we can't make work because of the light. But Suzanne, good afternoon, and thanks for being on the Healthcare Blog, and nice to see you.
Thank you, and thanks for coming to talk about Catalyst for Payment Reform.
So let's dive in. What is it?
Catalyst for Payment Reform, well, our tagline is the healthcare system needs CPR. And it's not just supposed to be cute, it's because employers really think that some drastic changes have to happen to make healthcare have the value that that could be affordable for American companies. And while this is nothing new, we've heard this from employers for years and years, including when I was starting the Leapfrog Group. I think what's different now is that we have health reform legislation having passed. Lots is going to change for the Medicare program, and if employers just sit aside and do nothing, they will be the recipient of policy being made for them. And so our goal is to come together to try to change the way we pay for care, to improve the quality of care and reduce the costs, and ultimately improve the value of the healthcare dollar.
Sounds easy. So before we dive into how we're going to do that, whether we can do that, let's talk about who's in the group at the moment. You've got some pretty major employers that signed up to be the founders. So who are they?
That's right. So we've just recruited a small group so far. We went after employers that are known to be innovative and progressive in the healthcare arena, and we hope to expand our group, not to be enormous, but certainly to have enough employers or other large purchasers that for each health insurance company, at least on the national scale that operates nationally, there will be enough of a customer base making the same demands that we can create some quick change. So to start, and I'll try to do this in alphabetical order.
If you get one wrong, we'll let them know.
I never did well alphabetizing when I was in elementary school, so I've tried to improve over the years. We've got the Boeing Company, we have Delta Airlines, and GE. And the Group Insurance Commission of the state of Massachusetts, which is the group that buys benefits for state employees. And we have Equity Healthcare. I think I'm out of order there, see? It's E before G. But Equity Healthcare is a group of about 34 companies, many of whom are invested in by Blackstone, who come together to buy health benefits. And that's now run by Bob Galvin, who was formerly with GE. And then we are also working with Intel and with Walmart.
Great. So many of those players have been active in health policy, but also you mentioned GE, which has been a long term, and Bob Galvin there, of course, now at Equity Group.
Right.
Long term sort of discussions and also activists in terms of employer healthcare. So let's get to the cut to the chase of the question, though, which is that we've had a lot from employers over the years. There've been business groups on health going back since before I was in healthcare, which is 1990 onwards. Yeah. And every year, and I've sort of poked fun at various employer groups saying, well, so you claim you're this active, but name me the other industry that's just put up with 10% raises from a supplier year after year after year. You say it's different now. We're hearing a lot sort of something maybe more dramatic than real about sort of changes in healthcare for employers brought upon by the healthcare reform legislation. Why is it really different now? Haven't they already outsourced all the jobs that were costing so much to India and all the rest of it? Why now?
Yeah, so I mean, it's a great question. I think I can answer that question in 2 ways. One is, in order to do payment reform, you have to have some way of judging the quality of care, because you don't want to just change the way we pay and then fall down into a black hole in terms of quality. That's not what anyone is after. It's not good for employers. It's not good for their employees. It's not good for the country. The only way we can do what we're doing today is because of the foundation that was laid by some of these same employers and through our work at the Leapfrog Group and other entities, where we insisted on national standards for how you measure healthcare performance, and where we insisted on public reporting of that performance, and where we at least started tweaking at the edges of payment reform with early pay for performance programs, other types of incentives and rewards, and even, for example, Leapfrog's never events policy, where we insisted that if a certain set of serious reportable adverse events happened, hospitals would apologize to their patients, they wouldn't bill those patients, they would publicly report the event happening to the proper entity that they were required to report to, etc. All of that has now laid the foundation for what we can do today with Catalyst for Payment Reform, because we have some fundamental ways, basic ways, of assessing the performance of healthcare systems. Now, we have a long way to go on that front. We need to have many more measures around costs and efficiency, and we've only just really scratched the surface in terms of all the quality measures. But that's one fundamental reason why today is different. The other is that with health reform, we are going to see payment reform happening in the Medicare program. And much of that payment reform is frankly going to be Medicare paying less and expecting more. And if the private sector, sits aside, then if I were a provider and I was going to get paid less by this customer, I would probably charge this customer over here a lot more. So employers...
They already do that according to most providers.
Yes. So employers are worried that if they don't at least align with Medicare and sort of work in tandem with some of the changes that Medicare is going to be implementing, if not step ahead of Medicare, then we are likely to just be recipients of whatever comes our way, and that's unlikely to be more affordable health care.
Right. So my old colleagues, Ian Morrison from ISTF and Bob Lightman from Harris, used to say that employers were cranky, confused, aimless, and spineless. But you're thinking that some of them are a little bit different. Let's talk a little bit about the integration or the interlocking position between employer reform and federal health reform, if you like. So first, sort of obvious is that how much discussion. We're in the office of PBGH. Peter Lee has now gone to go work, who was running PBGH, has gone to go work for HHS.
Right.
How much conversation between these large employers and the feds, how much coordination is they're going to be around these issues?
Yeah, I mean, perfect question. That is one of the goals of CPR, is to create a coordinated voice to communicate and dialogue with HHS around many things. And in fact, that's already happening. We have the benefit of Peter Lee knowing Catalyst for Payment Reform very well, because he was working on it before he went to HHS, and he has already demonstrated, as you can imagine, a keen interest in having the input of employers and consumer groups, given his background, as they're trying to determine what role is HHS going to play in overseeing and using its authority as health reform gets implemented. So, for example, employers are interested in some short-term wins. So is the Obama administration, because they've put out this bill that everyone is hoping and anxious to see is going to reduce costs. Employers are anxious to reduce costs in the short term. There are things that we can look at to do together. I think a good example of how this can happen is when Leapfrog implemented its never events policy. That was the precursor to the hospital-acquired conditions policy that Medicare put into place soon after, which would have been politically much more challenging to do if Leapfrog hadn't done it first. So I think that there's a role for CPR to play in, like I said a minute ago, stepping ahead of where Medicare is, but also as, for example, they get ready to put in rules about who gets to be an ACO, an accountable care organization. That's one of the key, delivery reform ideas in the legislation. We will get together as Catalyst for Payment Reform and put forward some criteria that employers think would be really important to maintain if accountable care organizations are going to ultimately lead to better, more coordinated care without becoming also monopolies and charging much higher prices, for example.
So do you think there's is what you're going to be talking about? There's been a lot of talk, of course, over the years about accountable care organizations, patients in medical homes, et cetera, as ways that you could do better coordination of chronic care, predominantly, and management of acute care issues. Is that the kind of thing you're going to be doing, or are you going to be doing more experimentation? I mean, is this more about implementation of stuff that we kind of think works already, or is it going to be more about experimenting with new models?
Yeah, great question. I think it's going to be a combination of both. I think CPR's belief is that the fee-for-service system, even though some of us loathe it, will be around for a while. It's not going to go away overnight, and that there are incremental changes we could make to it that could not only reduce costs in the shorter term, but could also prepare us for some of the bigger types of payment experiments we want to implement going forward. At the same time as we work on those short-term incremental changes, we will want to be looking at all of these new experiments happening and getting methods into place that will rapidly return results so that we can know what's working and what's not. I think one of the things that's scary for employers as everyone jumps on the ACO bandwagon or the medical home bandwagon is that, we are in some ways putting the cart before the horse. We are going to be implementing on a wide scale something that we really don't have a whole lot of evidence is going to produce anything better than what we've had in the past. In fact, integrated delivery networks in the 90s had a lot of challenges, and there are some differences with ACOs, but there's not a lot of confidence that things will be better. So I think we are going to be looking at a combination of implementing what we already know works, and then wanting to put into place some steps that will ensure we look very carefully and examine closely how other payment reform and delivery reform options play out, so that we then know how things need to be tweaked going forward.
So, one technical question and then a final question. The technical question is, what precisely is the catalyst, or your organization, or the institute, going to do in terms of providing services to its members?
Sure.
Tell me that.
Sure. So some very concrete, what I would call bread and butter services that employers can put into place very quickly that can make a big difference. That's where we're going to start. So for example, we will be putting together and are already working on a standard set of questions for employers to use with health plans in the sourcing process. So as they decide which health plans they're going to use in the next year, they issue these RFIs with lots of questions, and the payment reform module in that will be authored by Catalyst for Payment Reform, with feedback, of course, from the employers, and will also be aligned with Evaluate, which is some of your listeners or readers will know is a national RFI tool put out by the National Business Coalition on Health, so it will have even further reach than just our membership. So that will signal to the plans the kinds of things that we want to see them doing. Then there will be companion contract language, where the employers will put into contract with the plans what it is they expect them to be doing around the area of payment reform. An example might be, make sure that by the end of 2012, at least 15% of payments are tied to performance. That's one example of a criteria, that could be established, a criterion rather that could be established in health plan contract language. So that's some initial work that the employers can put into place immediately. We also are planning to create a national scorecard on payment reform, so we can track the nation's progress on payment reform and keep the urgency of the issue at the forefront of people's minds and imaginations. And then at the local level, we have some tools that will be coming out next month, a market assessment tool and a series of action briefs that help purchasers and other stakeholders, frankly, assess the characteristics of a given healthcare marketplace, how are different types of payment reforms and delivery reforms likely to play out there, and then what are concrete steps that purchasers can take to tweak things in a direction that will be in their favor and that of consumers. So those are just some examples of the kinds of things that we'll be doing.
So, last question. If I'm back here in 3 years, how do you tell you succeeded? What does good look like?
Great question. The goal of Catalyst for Payment Reform is not to be a permanent institution. It is to spark change, hence the name Catalyst. And what I think good would look like would be that, I'll go back to the example I just gave, a much higher proportion of payments would be tied in some way to the performance of providers. That's one very measurable thing. Right now, our estimate is that between 1% and 3% of payments are tied to performance. It should probably be something much larger than that. Let's say in 3 years we could hope for maybe 40%. And we would certainly like to see employers working together in combination with their health plan agents, and also employers working directly with providers to create environments that are more conducive to improvement in healthcare with payment reform as a vehicle.
Great. Thanks so much, Suzanne. I've been talking with Suzanne Delbanco. She is the Executive Director of the Catalyst for Payment Reform, or Catalyst for Payment Reform, new organization, and she probably has one of the better views of anybody from her office that she's in at the moment. So now we're going to get to show her on that. There you go, that's the Bay Bridge and Treasure Island out the window from San Francisco with the little arrow and the Embarcadero Wall walk. Suzanne, thank you so much.
My pleasure. Thank you.